Hello. Thank you so much for the opportunity to present as part of the vEDS Virtual Summit for the Ehlers-Danlos Society. I'm excited to talk today about vascular Ehlers-Danlos syndrome and pediatric manifestations. My name is Shaine Morris, and I'm a pediatric cardiologist at Texas Children's Hospital and Baylor College of Medicine in Houston, Texas. I am the medical director of our Cardiovascular Genetics Program, which has a strong focus on genetically mediated aortic and arterial disease, and we specifically have a focus on vascular EDS. So let's talk a little bit about vascular EDS in children, which is a little bit different than how it often presents in adults. So in children, the features most commonly identified as the reason for testing are family history, and this is obviously quite different than in adults. Also skin and skeletal signs, so signs of easy bruising, hematomas that seem out of proportion with the injury sustained, thin-skinned, and sometimes joint hypermobility, but joint hypermobility is quite common in children, so it has to be in combination with other findings. And unlike adults, presentation with a critical event like a intestinal rupture or an arterial rupture is rare. If you look on the right, this is the distribution in our clinic, where about 28% presented with family history and 72% presented with some sort of clinical feature. Now, in published literature, family history can be responsible for as much as 60%, but I do think as people are recognizing the signs of vEDS more commonly now, it is more common to present with clinical phenotype, but it tends to be more subtle presentation than in adults. Of note, it's common for child abuse to be suspected given the significant bruising in some cases. I have at least 4 patients in which their parents have been reported to protective custody because of the frequent bruising in different stages of healing. And so this is something to be wary of. If you find a child with multiple areas of bruising, really consider vascular EDS in the differential. So we can talk a little bit about birth. So the first time you might suspect this is when infants present. So some common things we see are club foot and hip dislocations, although of course those are common in children otherwise. Also, if you have someone with limb deficiency or amniotic band syndrome, keep vascular EDS in the differential. Of course, it's not the number one cause of these, but it's something to consider and has been reported. More rarely has been reported is a neonatal pneumothorax. So as a baby is getting, just in the newborn period, has a pneumothorax, or we've had at least 2 patients reported with pyloric stenosis. It's hard to know if there's an association there, but that is a rare congenital anomaly. And the fact that it's been reported at least twice in vascular EDS makes us suspicious. So one thing that we've recently noted is that preterm birth is quite common in vascular EDS. This is in patients, children affected with vascular EDS. We recently looked as part of our research study at the percent that were born before 37 weeks gestation. So if you look at this bar graph along the vertical axis is percentage that were born before 37 weeks. In the first column is the vEDS cohort, and the second is the general population. So you can see that in the general population, the likelihood of being born preterm is about 14.8%. But in our cohort, it was 46.7%, which is much more likely. And the thought is that perhaps the amniotic sac, which is formed of the fetal cells, is actually more fragile. And this is why perhaps they're born more early. This is looking at that same information, but in a more detailed way. These are 3 graphs. The far left is actually looking at the median gestational age. And we've actually split the category by what kind of mutation the patient had. So on the first graph along the y-axis is gestational age. So the gray band is when normal gestational age between 37 weeks and 40 weeks is when we feel like we consider normal gestation for a child. And in the first box plot is patients who have a glycine or splice site mutation, which you probably have heard from other speakers, is sort of, we think, are the more severe mutations, versus the second box plot is null or multi-gene deletions, where there's just less effective collagen or less collagen. And so you can see in this box plot that the patients of glycine or splice site mutations, their mean gestational age is below 37 weeks. So half of these patients are being born preterm versus the null multi-gene deletion. They're right in the middle of the gray, so born on time. So it does look like this is mostly occurring, these preterm births, in patients who have a glycine or splice site variant. If you look at the second graph, this is looking at it a little bit different way. Instead of looking at gestational age, we're looking at birth weight. So the gray area is what's considered a typical birth weight for a baby, 2.5 kilos to 4.5 kilograms. This is in kilograms. And again, we've stratified it by glycine splice site mutation or null mutation. And again, you see the same pattern. The null are multi-gene deletion. They're right in the middle of the normal weight range, but glycine splice site are, a little less than half of them are in the low weight range, which makes sense. If they're born early, they're likely to be born less weight. So this is why we did the third box. And this is when we looked for birth weight adjusted for gestational age. So that's saying, are they actually small for gestational age, or are they just small because they're born early? And you can see that these are nicely in the gray area, which says babies with vascular EDS seem to be appropriate for gestational age. They're just being born early and therefore have low weight. And again, if you look here, both of them are in the gray box. So a summary of this slide is basically that children with vEDS, especially with glycine and splice site mutations, seem to have a much higher likelihood of being born early and low birth weight. So what are the most common features as kids get older of vEDS? So in our research and other people's research, the most common presenting features are prominent veins over the skin, prominent eyes, easy bruising, and hindfoot deformity, which is an ankle deformity where the ankle kind of seems sort of more lax or deviated laterally. We're going to look at some pictures here. These are some of the amazing patients in our research study. These are all children with vascular EDS. Some have null mutations, some have splice site or glycine mutations. And you can see that the features we see in adults are present in children, but sometimes they can be very subtle. Features that we see are large, deep-set eyes, thin or pinched nose and thin lips, a small chin. Some people have gum recession and fragility. And again, it can be very subtle in children. If you look at these kids and saw them on the street, I think some of them would be very hard to tell that they had vascular EDS. These are some pictures of some of our young adults and older adults, just so you can contrast the young features with the old features. People who are older tend to have less, more definition in their face, and children still have a little bit of that more round face, but I think the eyes stay pretty consistent, the really deep set eyes and the thin noses. So skin, just like in adults, can be translucent. The veins are visible below the skin, especially on the chest, abdomen, the lower back. Also, the skin can be soft and velvety, but not overly stretchy like in classical EDS. And a big thing is they're very easy bruising and tearing. Very minor trauma can cause very major injury. You can see one of my adorable young patients here was just these major bruisings. A small hit to the head caused a large laceration. They can have acrogyria, which is aging of the skin in the hands and feet, but it can be pretty subtle in children. It can just look like their skin is a little bit dry. It's not nearly as evident as it is in older patients. And the much bigger risk factor is the easy bruising and the easy damage. Now, that's not everyone. Certainly patients with null mutations are less likely to get that and might sustain the injury normally. So skeletal features, as I mentioned before, they can have clubfoot or hip dislocation, which is present in the newborn period. And same with the limb deficiency or amniotic band syndrome. They can also be small and have a short stature or just less than the 15th percentile for height. Joint hypermobility, as you see on the right, this is one of our older patients, but demonstrating it really nicely. She has knee hypermobility and shoulder hypermobility can be present. But again, this is really common in children in general. So it certainly is not an isolated finding in vascular EDS. So this is another thing we've been looking into is bone density. So we know that in other forms of Ehlers-Danlos, low bone density is common, but it hasn't really been fully explored in vascular EDS. We've been looking at this recently. So this is an evaluation of bone density looking at DEXA scanning. DEXA scanning is an assessment of density taking into account sex and age. And so on the far left, you can see the Z-score. So a Z-score between -2 and +2 is normal, and the dotted line is average. And we're looking at 3 measures of bone density here: the femoral neck, the lumbar spine, and total body. And the green boxes are sort of where our patients are lying. So you can see that the majority of the boxes are below the dotted line. So they are on the below sort of mean, but we only have a few cases that are below the -2. So we're showing that our patient population trends to have low bone density, but only a handful of them have true low bone density, which we would count as below -2 Z-scores in these 3 areas. And it seems like femoral neck and total body are the most affected. We look at this a different way. This is what % of patients have a DEXA, at least one DEXA Z-score less than -2. And you can look here, oh, sorry for the little bit of overlap there on the left, but you can see it's about a third for femoral neck and total body. About a third of our patients have at least one of their bone density evaluations less than -2. Lumbar spine's a little less common, and about a third have low bone density anywhere. This is looking at it by genotype. So here we didn't have too many patients that actually had undergone bone density screening that had null or multi-gene deletions. So this is separating glycine, which is the G at the bottom, versus splice site, which is the S. This is the same Z-score graph with the dotted line being 0. And you can see that those with splice site mutations tend to have lower bone density than those with glycine, although this doesn't meet statistical significance because when we divide it up this way, we have pretty small populations, but you can start to see the trend, and we're continuing to study this. So what about congenital heart disease and other echo abnormalities? Traditionally, we don't think of vascular EDS as having much congenital heart disease or vascular anomalies inside the heart itself or inside the aortic root. We looked at this with our population of patients, about 29 patients who all went detailed echocardiography at our hospital. And we actually found about 27% had an abnormal echocardiogram. Now, some of those were congenital heart disease. This included bicuspid valve, Epstein anomaly, atrial septal defect, subaortic stenosis, and a left superior vena cava, which is considered a benign anomaly, that last one, but it is a congenital heart defect. And then a few had aortic dilation, that was 3. And some people, 2 of our patients had both aortic dilation and congenital heart disease. But unlike Marfan syndrome or Loeys-Dietz syndrome, which are considered other connective tissue disorders, aortic dilation is much less common. And, we don't know if it really has a strong association with the risk of dissection or rupture in vascular EDS. But regardless, about a third of our patients did have an abnormal echocardiogram. So what about complications and emergencies in children? So the biggest complication is certainly these large hematomas and vein ruptures. We see our patients come in all the time, either from trauma or spontaneous. They get these large hematomas that can be quite painful. We've had a few patients need to be hospitalized, or we had a patient example who was in a motor vehicle accident and just had a horrible skin damage and hematomas all over. So this is one of our most common presentations. Now, certainly aortic events can happen, and arterial events, I'm just going to go over this quickly. The difference, I think someone did this earlier today probably, but telling the difference between an aneurysm versus a dissection versus a rupture. So an aneurysm is just a dilation of a part of a blood vessel. So on the left, you can see all our arteries, and the aorta is the largest of those. In the middle is showing an aorta and a root aneurysm, which is the bottom of the aorta, or an ascending aortic aneurysm, which is sort of the middle. But you can actually have aneurysms anywhere. An aneurysm is just a dilation of an area and not a tear or rupture. And these are asymptomatic. They do not have pain. Now, when we look at a dissection is a tear in the wall. So if you look here on the right, the arteries have multiple muscular layers. And if there's a tear into the wall that doesn't go all the way through, it can cause a false lumen and create a middle layer. And that's called a dissection. That can cause extreme pain. And the main complication of this is that wall that it creates, that other lumen, pushes this wall in and can cause obstruction of blood flow. So that can happen in the aorta, like in this picture, or it could happen in a carotid artery, like this picture, which can give symptoms of a stroke. This is also a dissection. You can see the bleeding comes in, and so the wall of the lumen reduces blood flow to the brain. And a rupture is when all 3 layers tear and it bleeds. For example, this is an aorta, so it bleeds into the chest cavity. And this is almost always leads to death if this occurs. So in children, thankfully, these events are quite rare. This is looking at our cohort of 29 patients, pediatric patients up to age 15 or up to age 18, and seeing how many patients had events. And we had 4 events, 3 of which were arterial. So we had 1 bladder rupture, but in our cohort, we've had 3 vascular events. Now, 1 was a huge aortic rupture, but it was during congenital heart surgery. So it wasn't a spontaneous rupture. It was while the child, who they did not know the child had vEDS, had aortic surgery, and the aorta just fell off and ruptured. And then we have 2 twin boys who have splice site mutations who've both had carotid artery dissections at different ages, one at 9.9 and one at 12.2. One had stroke-like symptoms that resolved and one was asymptomatic. So all 3 of these patients with arterial injuries, as well as a child with a bladder rupture, did survive and are currently doing well. So other complications that can occur just like in adults are a pneumothorax. That's a collapse of the lungs. This presents with shortness of breath, low oxygen, and chest pain. Hernias are actually quite common in the groin area, and these can be repaired in vascular EDS with good success. Recurrent joint subluxation or dislocation can occur too, and rarely this has to be surgically stabilized. Intestinal rupture can certainly happen. We thankfully only had 1 patient in our cohort that has had this, but it can happen and presents with acute abdominal pain that can be progressive, and surgery is usually the treatment to resect the injured part of the intestine and can later need for permanent intestinal resection. So what about overall survival? So if you look at the survival curve, this is from the classic study from Dr. Byers' lab by Pepin et al. I put a line at 18 looking at children. You can see that pediatric survival is quite good. Most events that affect survival happen later in life, and hopefully we're really changing the course. So these curves look different in the contemporary era. And the good news is that even when children have life-threatening events, they're almost always survivable. These are some other reported injuries, and these are patients who've undergone surgery. So a 13-year-old who had multiple aortic surgery for aortic aneurysms, a 15-year-old that had successful repair of a right subclavian artery aneurysm, a 13-year-old that had a stent after a dissection, and a 14-year-old who had a near lethal rupture of subclavian artery. So these are all repairs that occurred in children who had events. And watching can work too. Sometimes the event doesn't need an intervention. So this is an example of a child who had a femoral leg artery dissection, but it didn't occlude perfusion to the lower leg. And so just close imaging was performed and medical follow-up, and the child did well. So what about medications in children? I'm happy to talk offline or in the Q&A period about this. The overall point is there's very little data. Many practitioners, including myself, do use beta blockers given the low side effect profile. These are tolerated very well, and possible benefit looking at the French study of celiprolol, although I think a lot more needs to be known. Some practices, including I believe in Baltimore and the UK, use losartan. And the thought behind this is there's good blood pressure control and reduced stress and may have a benefit, especially given the benefits shown in Marfan syndrome. The point is we definitely need more studies, and that any of these trials coming up really need to include children so we can understand if children can benefit from medical therapy in vascular EDS. So basically, in summary, children are less likely to present with life-threatening complications. The phenotype can be subtle. Common features are thin, translucent skin, easy bruising, and aged hands and feet. Prematurity and low birth weight are common. Low bone density can occur. But most children do survive major events. And ultimately, we need more work to understand medication efficacy in children so children can live more freely and less limited, and so that we can reduce events in adulthood. So just as a final slide, I want to show you our strategy when we meet a patient with vascular EDS in our clinic, just in case anyone is also seeing these patients. We basically confirm the genetic diagnosis. We perform cascade screening and testing relatives if indicated. We always do baseline head to pelvis imaging, usually an MRA to reduce radiation, to look for any subtle aneurysms or undiagnosed dissections. We ensure families are educated about risks, warning sign, emergency plans, school plans. We talk about activity limitations for older children. We do not limit younger children typically. We in our practice do start beta blocker therapy, usually labetalol or carvedilol, because those are 3rd generation beta blockers that can have vasodilatory effects. We do serial imaging depending on the frequency, depends on severity and the genotype. We try to minimize procedures, but if we do need them, we have a team prepared and knowledgeable about what needs to go on. And we really work to connect our new family with other families. So I just wanted to thank our vEDS research coordinator, Sarah Stevens, our clinical CV genetics team that sees patients with vEDS and cares for these patients here on the left, our amazing collaborators in all of this work, Dr. Shireen Shalhoub, Peter Byers, Dana Milowicz, Siddharth Prakash, and many others. Our funding for our research is from NHLBI, the Lauren Ovalgone Tenney Memorial Fund, and Baylor, my institution, and the phenomenal advocacy, of course, from the Ehlers-Danlos Society, in addition to Rachel Tays and running a Facebook page, the many vEDS families that contribute to our research, and of course, the vEDS movement and vEDS Collaborative. I'm happy to answer any questions at all. Thank you.